Funding for This Is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Blake Farmer, and this is Nashville with a special Roundabout edition. We have all been touched in various ways by the opioid crisis. Perhaps it's you who've been fighting your way towards sobriety and stability. State health officials put the figure at roughly 70,000 Tennesseans who are in an active addiction to opioids, and the impact ripples out from those 70,000, as you know. Parents who've tried everything, family members who've lost contact, friends who don't know how to help. And as we've heard this week during our focus on harm reduction tactics, we all of us stigmatize hard drug use in some way. Even the people we've had on this week who have made it their life's work admit we all stigmatize. I do want to widen out the conversation today because substance use and abuse is incredibly pervasive. The national agency that tracks these numbers says that in Tennessee, more than 1 million of us have an active substance abuse disorder. Alcohol, pills, illicit drugs, 1 million, 1 in 7. And whether we see it or not, there is harm reduction going on everywhere. In Monday's story, where we follow the renegade work of Miriam Field, she points out that going to a bar involves harm reduction, as bartenders are required by law not to overserve their customer. Makes you think. So we've talked about syringe exchanges, overdose reversal drugs, fentanyl test kits, even smoking drugs rather than injecting them as forms of harm reduction. It's all about helping people use more safely rather than focusing on stopping the risky behavior, at least right now. Today is your chance to jump in on this discussion. The phone number to join us on air is 615-760-2000. You can also stream video today from the studio. It's at youtube.com/@WPLN. And if you are getting that visual experience today, just simply drop a comment in the live stream, and the team will work it into the conversation here while we're on the air. We'd love to have your first name along with your comment, if you don't mind. All right, today's Roundabout panel, who's in the room listening to me go on and on, but they're here to help field your comments and questions. Brittany Miller is in recovery, now a certified peer recovery specialist. Dr. Josh Winskowski oversees patient care for 13 Cedar recovery offices in Tennessee, and he's over their telemedicine division. And Megan Barry, the former mayor of Nashville, lost her son Max to a fatal overdose while she was in office. Thank all of you for being here, and welcome to This Is Nashville.
Thanks.
Yeah,
thanks for having me.
Well, all right, Megan, let's start with you. I've read your book, It's What You Do Next,
Thank you.
I have a good sense of Max because you talk a lot about him in there.
I do.
But bring him into the room with us. What was he like?
Sure. Max was a great kid. I mean, I think every parent says that. But and Max's substance use journey started smoking pot in high school, and then he became addicted to Xanax as a junior in college. And, we were lucky because at the beginning of his addiction, we could get him home. We got him into treatment, and we had 3 things that a lot of folks don't have. We had a willing kid who was willing to go to treatment. Mm-hmm. We also had a bed available, which is not always common, and we could pay for it. And those are 3 things that a lot of families don't get, but we did. And Max did go through treatment. He was in recovery, but, a lot of times we don't realize all of the things that we are going to, see with recovery. And we were stupid. We didn't pay attention, and Max didn't either because he really thought that he had checked the box and he didn't ever have to deal with this anymore.
Oh, wow.
And that's not uncommon. And we never talked about it. And I'm so thrilled you're doing this because part of this and part of my reason for being here is because we have to lift the shame, the stigma, and the guilt. And if we do that by talking about it, then other families can walk through this, hopefully with a better outcome.
It does make me wonder, though, because the way you talk about Max, I think he's kind of, would he be rolling his eyes at this conversation right now?
Sure. Yeah, probably.
But really, what would he be saying now about this concept of approaching addiction in a more of a harm reduction mindset?
I think Max would actually, he was like a lot of folks who struggle with addiction. Yeah. He also, got addicted to Xanax because he had anxiety, and that's not uncommon to have some kind of a part. And I know that Dr. Josh talked about that. We talked about that earlier. you have to have the mental health along with the substance use disorder treatment together. And Max didn't have that.
Yeah. Appreciate the calls that are coming in. Chris, Rachel, we'll get to you guys soon. Brittany, talk to me. Your substance abuse also began young, but I mean, it sounds like you kind of really kept it together for quite some time. When did things fall apart?
So things actually fell apart probably to my mid-30s. 35 is the age that I got clean. So I was pretty successful at hiding my usage. When we look at life falling apart, it's easy to, on paper, things look well. I was able to function, have a job, make good money, subdivision, good car, kids go to nice school. But the self-concept that I had inside was just broken.
What do you mean?
It's those feelings of guilt, shame, worthlessness. I had pretty much just resigned from life. I had watched dreams over the years kind of fall apart, not come back together. So even though on paper things looked okay, on the inside I was just miserable going through the motions. So that was my solution to the problem for a long time, was I just didn't have to deal with that reality.
What kind of help did you need ultimately to get into recovery at 35 years old?
Some people get the nudge from the judge. I got the nudge from the physician. I've got to a point where my organs started failing on me. Just one day, demonstrably ill, go to the hospital, and they said the only way that you can be considered for an organ transplant, which is what you need to save your life, is to complete an IOP program and demonstrate 6 months of proven being clean and sober. So that got me into treatment, and the people at the treatment center not only did a wonderful job with some cognitive behavioral therapy, but they also insisted that I go to 5 outside meetings a week, and was able to start building that structure while I was still in treatment. I was chairing meetings before I ever left residential.
Meetings is sort of like AA meetings, or?
NA, but they're all kind of based the same. Right. NA is based directly off of AA, 12-step programs. There's Celebrate Recovery. There's Smart Recovery. There is a program that will fit anybody who's looking.
Yeah. All right, so Dr. Josh, you say Cedar Recovery takes a harm reduction approach to treatment. What does that mean at this moment?
Harm reduction means taking medications and using those to help people with their substance use disorder. And harm reduction, to me, buys me time so I can address those co-occurring mental health needs. It buys me time so I can make the changes here.
You're pointing at your head, yeah.
The prefrontal cortex and internally in the heart. And it allows us time so that we can begin the life repair that happens, because substance use disorders can be so destructive both to physical and emotional and social structure and well-being. And if it gives me time to rebuild somebody's support systems. And have you guys ever heard of Maslow's hierarchy of needs?
Yeah. I mean, don't make me recite it.
Big picture, Maslow, think of a pyramid. He was a really smart guy like 100 years ago, and he was studying what it took to make a happy and healthy person. And I divide it into 3 layers. Your base part of the pyramid is your food, water, shelter. Your middle layer is your people in your community, your village, the things you depend on that secure your food, water, shelter. And then the top part is self-actualization, reaching my purpose in life, my mission, my values. Harm reduction buys me time so I can fill that pyramid to get people rebuilt and to repair people, because people do repair. Big picture, 70% of people recover from a substance use disorder lifelong. If you add a year of treatment, that goes to 80%. If you add 5 years of treatment, that goes above 95%. We used to think it was a death sentence. It can be, but it's not anymore. We've got treatment, and harm reduction buys us time so we can add those years back.
Well, I'm Blake Farmer. This is Nashville, and it's your turn to talk. We've been focused on addiction and harm reduction this week. It touches so many of us, including folks who are on the phone. What's your experience? What's worked for you? Do you see any downside to going all in and saving lives and leaving the addiction treatment for another day in harm reduction? Number to join us on air is 615-760-2000, or comment on our video stream at youtube.com/@WPLN. Let's go to Chris, who is calling in from Nashville. You're on This Is Nashville. What do you have to say?
Yeah, hey. I'm in this business, and, we have great potential to treat people.
And by this business, you're a physician, correct?
Yeah. So we're in the pain management, but also the rehab business. And the legislature's made it so difficult to maintain licensure and to qualify to be a pain management center, to be a rehab center, that we're losing tons of great physicians. They're going to other states, and these patients are left in the lurch, and they're still addicted, so they're going to go to the street, and that's where they get the adulterated drugs, and that's when they die.
Hey, Chris,
No
can you
one's
talk to me
dying.
about what it is? What is it at the state legislature that would make your job hard?
The rules, the rules of licensure for the clinics and for the physicians to provide the care.
Yeah, and this is
Both
on the pain clinic side more than the treatment side, right? I mean, I'm actually a little interested in this. You're saying that you run both a pain clinic and like a clinic that does medication-assisted treatment for opioid use?
Our corporations involved with both.
I see.
And, my colleagues, my peers, I can tell you there's dozens in the last 5 years that have just thrown their hands up and said, enough's enough.
Yeah.
We're getting nickel and dimed, and we're being made the bad guys in this.
Yeah.
The restrictions or the regulations are kind of punitive. And these docs and these nurse practitioners just say, enough's enough. I'll go to Kentucky. I'll go to Bama. I'll go to North Carolina, where the environment's more conducive to a partnership.
Yeah, Chris, we've got your point. We appreciate it. Dr. Josh, how do you respond?
Man, Dr. Chris, I am there with you so much, my friend. And the way we kind of see it at a public health level is when the opioid epidemic and crisis really happened in those 2000s, it became corrective. And when you correct something at a public health level, the pendulum swings really far. And that's when we get legislative that can be really restrictive. And even back in like 2015 and 2016, Tennessee was going to try to ban buprenorphine. They were trying to outlaw it.
I recall people calling a clinic like basically a pill mill if you were a Suboxone clinic.
They were, because we didn't know anything about it. Addiction medicine didn't become a specialty until 2016.
Wow.
This is new science. This is new information, new practices. So just now in the past 5 years, we're seeing that pendulum swim back the other way in the other direction. And we're starting to see how beneficial it is for folks like Dr. Chris to partner with recovery and pain management. We're starting to see deregulation. We're starting to see it be so much easier to access treatment now.
Yeah.
Well, and access to treatment, I think, is also the biggest challenge. Having looked at Tennessee and our rural hospitals or lack thereof, you've got access and potential at the federal level to pass some really meaningful legislation like the Modernizing Opioid Treatment Access Act, which would actually allow medicine to be delivered through the pharmacy model, which, again, there's all kinds of ways to get treatment into the hands of people, and we have to be much more creative.
Are you saying that instead of having to take a prescription from Dr. Josh and go to the pharmacy, that it could be dispensed directly?
There's opportunity to actually, especially in places where you don't have a hospital or access to doctors.
Well, and we heard yesterday on the show about efforts to have mobile medication-assisted treatment, which I believe Cedar Recovery has begun. But can you dispense the medication from your unit?
We can. We have pharmacists on site at some of our units that we're starting, and we've got grants from both state and federal that help us fund some of these mobile units, and they can meet with a peer recovery specialist like Brittany through telemedicine. They can see their physician and provider, and then we can pay for their medication through this grant through either the mobile unit or send it to a partner pharmacy in the community.
Well, we want to hear more about that at some point. Rachel, you're on This Is Nashville. What do you have to add to this conversation?
Well, I'd like to add a different tone to this, and
Please.
I'm sorry I may not be the best speaker, but I have a small cleaning company, and my body depends on very active work. I had a terrible car crash in 2011, and no medicine worked on me. Well, they put me on the opioids, and I do not abuse them. I take them as needed. And for the last 11 years, they have worked great for me. I am up out of bed. I can work. I can think clearly. I can drive. And of all things, I can still clean houses. And ever since, I'm calling outside of Nashville, ever since 2016, the opioid crisis, and I'm so really tired of hearing that, the meth in our county alone, the overdose of meth,
You're saying meth as in methamphetamines.
Methamphetamines. They are easier to get on the streets, and people in my county are overdosing left and right.
Yeah, Rachel, what county do you live in?
I live in Ashland City.
Ashland City, okay, Cheatham County.
Tennessee.
Yeah. Well,
Yeah.
Rachel, we'll take that from right there, and thank you so much for sharing that perspective. I mean, Dr. Josh, it's a good point. And listen, guilty as charged that we can sort of think everything's opioid. You go look at the numbers. It's like it's 2/3 of overdose deaths, but it's not nearly all of them. Talk about the problem with methamphetamine.
Man, Rachel, you are 1,000% correct. And this also goes to Dr. Chris's point, too, is the extensive regulation has shut down and in some ways decreased the supply of both prescribed and illicit opioids. And so for the first time, we've seen decreases in opioid death rates, but then the flip side has been an increase in stimulant-related related overdose deaths.
Meth is included in a stimulant?
Yeah, meth and cocaine and MDMA. We've seen a lot of that because if you can't get one, people go for the other. It used to be a speedball where you mix the two, but now if I'm coming off of opioids, people will use meth or stimulants to when they can't have access to it. And so you see a lot more like heart attacks and ER visits related to stimulants.
Brittany, go ahead.
It's kind of to feed into what the general conversation's been, not in reference to methamphetamines, but in reference to medically assisted treatment in general. A lot of the red tape that people experience in the whole of this area is simply access. And I can't tell you how many people that I work with on a daily basis that they're trying to do the right things. They are under a physician's care. They are seeing a psychiatrist. They have been cleared to take this medication. And there's lots of hoops that they have to go to not only be prescribed it, but to have access to it. And when I have people in rural, low-income areas, and they have to travel a county or two away to be able to go to a clinic who can see them and can treat them.
For pain management, correct?
For pain
Not for
management
addiction.
and for addiction, for both. Both of these things.
Well, that seems like the complicated thing is you're being treated for both at once.
There's not enough access for these, then therefore they're going to end up going out to the streets and getting illegal substances. And that's where we're seeing a lot of the harm. So access to these is a huge red tape issue that I'm finding in this area.
Well, and I think that, one of the things that we're hearing is drugs affect people differently. And there is no one size fits all, but what you have to have is kind of a menu of what's going to work best for the person who is actually in front of you. As Rachel said on her, she can function. This is how she lives her life because she has access to a medically prescribed drug that helps her. That's not going to be for everybody. But so, I think what we have to get our arms around is if you treat the person, then you can, whomever's presented in front of you, you can give them what they need.
Well, we need to take our first break. Ron, George, hang on the line. We'll be coming right back to you. And if you'd like to join us on the air, talk a bit, keep this conversation going, join the queue at 615-760-2000. Also, feel free to drop your comment on the YouTube stream if you're watching there. It's youtube.com/@WPLN if you'd like to get a visual experience today. This is Nashville. Stay with us.
Funding for This is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Blake Farmer, and this is Nashville. It's a special weekly Roundabout episode. Our panel all has experience with addiction and recovery and are here to take your calls. The number is 615-760-2010. Or you can comment if you're watching on the YouTube stream, just right there at youtube.com/@WPLN. Infinite Valence says, shoot, access even to ADHD medication's a nightmare. I have to pee in a cup even though I have no abuse history just to treat ADHD. Yeah, listen, it's not just about opioids as we're hearing this morning. I guess it's afternoon now, isn't it? Let's go straight to the phones. Ron in Memphis, I believe you're with Better Way, correct? You're on This is Nashville. Ron, you there?
Yeah, I'm here. Can you hear me?
Yeah, I can now. Sorry, that's probably my fault.
It's okay. Yeah, I am from Memphis. Operate an SSP there, and
that's a syringe exchange programs, correct?
Yes, sir. That is. Yeah. And Mike, I just want to discuss, we have a lot of folks that we see that are unhoused and uninsured, and about when they do reach out to, let's say they end up in an ED or some, an acute care setting, how they're treated a little bit differently than someone that walks in with a different type of care that's needed, and just navigating the path for the uninsured, and what goes on with them. It's a difficult proposition, to follow up. Just like your panel was talking about, the lack of transportation, the lack of ability to be at appointments if they're specified for them, we have to create a different environment,
Yeah, I absolutely agree.
Yeah, and sorry, we may have a mic issue here, but Ron, thank you for that point about your syringe program in Memphis, and maybe some of the stigma that goes with, when they need to show up in an ED. What have you seen, Brittany?
No, I absolutely agree with what it is he was saying. I work with a lot of people that come in acute.
Acute meaning what?
Acute meaning that they are typically in a moment of crisis. Things are not going very well for them mentally and or physically. These are the people who walk through the door at your emergency rooms, people who find themselves being involuntarily committed to places. There is way more unhoused than we have beds right now. There's not enough grant funds for people who have no income to be able to get into even transitional living facilities. So providing that stability, that is treating the whole person, not just the problem. It is very difficult for someone to seek treatment and manage that care if they don't have those basic stabilities that Dr. Chris was talking about earlier.
Well, and I didn't exactly reintroduce our panel here. Brittany Miller, a certified peer recovery specialist, Dr. Josh Winskowski of Cedar Recovery, and Megan Berry, former mayor of Nashville, who lost her son to a fatal overdose. So, Brittany, this idea, though, that you show up in Vanderbilt's emergency department or any ED and maybe are treated a little bit differently. What have you seen in that way? What's Ron talking about in Memphis?
I think what you're truly seeing is there is a lack of empathy, a lack of understanding for what they need. They look at someone as someone who's just making these choices, that they're making poor choices every day without the understanding that you see the choices they made, but you're not seeing the options that they had.
Maybe.
Yeah, I agree. We continue to treat this like a moral failure as opposed to something that is actually a chronic condition that can be treated. And we would never, ever, ever expect cancer patients to be unhoused or on the side of the road or unable to access housing because of their disease. But we absolutely treat folks who have substance use disorder exactly like that.
Yeah, let's go back to the phones for just a second. George, you've been hanging on there for a while. What do you have to say? You're on This Is Nashville. George, you're on This Is Nashville if you're still there.
Oh, I'm still here. Well, I have a chronic condition. I have my thoracic is fused, and from T12 down, all my lumbar is basically welded together.
Yeah.
So my problem is because of this opioid crisis, I have a hard time getting them, and I have a doctor, so I can only get 10 milligrams, all I'm prescribed, although I do take five of them a day, but I work between 12 to 15 hours because I have so many doctor bills I have to pay for. And so I have to nonstop work.
Yeah.
And really, those opioids they take the edge off. It's basically all it is.
Yeah. Well, George, have you had this experience where you're at once being treated for pain while also being treated, essentially like it's an addiction to opioids?
No, but I feel like I just feel like I'm looked at differently. Matter of fact, sometimes I look at myself differently, and I've tried to get off, but I have to work, I have to eat.
Yeah, George. George, thank you. We're going to try to work in some more calls, but so grateful for your input here, Dr. Josh. Talk to George directly here about this guy, that he's looking at himself differently, that he has somehow sort of failing because he's needing this pain medication.
Man, George is experiencing the failures of a medical system that have been so regulated that now he's losing access to the correct medical care that may be appropriate for him because the system has overcorrected out of fear because we didn't used to understand who may be the most at risk for substance use disorder. And so because of that, everyone gets treated differently. Big picture, the risk for substance use disorder, and I think that's the core of the question, is George is being treated differently because people are worried and they're putting him in a category that he may develop an addiction or a substance use disorder. Even if he doesn't qualify for that, even if he's not an at-risk candidate, he's being treated as though he is one. He's being stigmatized because of these overcorrections at a public health level and the over-legislation and the over-regulation of substance use disorder treatment.
George, really appreciate your call. Let's take another call from Clarksville. Mary, you're here on This Is Nashville. What would you like to add to the conversation?
Hi there. I just wanted to affirm what one of the panelists said about lack of access being a really huge barrier for people who are facing or who are going through recovery treatment. I used to do medical transportation, so I would take folks from Ashland City, just really outlying areas, rural areas, to Nashville to go pick up their methadone. And I had occasion to talk to a lot of them and listen to a lot of them about the challenges that their transportation posed to them, like rides being canceled. And if they don't go every single day, if they don't have like perfect compliance, they get kicked out of the program.
Mary, are these people having to pay you to bring them to Nashville so they could get methadone?
I mean, they never paid me.
But it was like their insurance or something?
Yeah, usually.
Medicaid will pay that or something?
Or possibly some sort of assistance program.
Yeah.
Could have been.
Well, that does seem like a huge issue, Brittany. I mean, you're in the peer recovery space working with folks. How much, like, what do those barriers look like to being treatment like at a methadone clinic or getting buprenorphine, Suboxone?
Well, transportation is a huge barrier. Insurance is a huge barrier too. We can have the broader discussion. It's great if you have private insurance, you can see a doctor, if you've got Medicaid, but there are so many people who do not qualify for Medicaid at this point in time that they are falling into between the cracks where there is zero coverage for them whatsoever. They have no affordability. And I have recently experienced working with people who we are having this whole conversation about harm reduction. We talk about people on the streets, people out in public, from the prison institutions to our county jails at this point. When people are coming into those facilities, they are being given MAT.
Really?
If they come in and they have a positive drug test for certain substances, they're starting that process in jail.
Wow.
So now
you're saying like a county jail?
County jail. So we are sending people out of prisons and jails and onto the street, and they've got no insurance,
so they
no
started
housing.
Suboxone perhaps, and then they lose their supply.
And they lose that supply of that. So, and what are the people to do when no housing, no job, and they do not qualify for Medicaid?
Well,
there's places out there that can help with transportation, but it's very slim.
Well, and I mean, let's just say, Tennessee is one of the states that has not taken the expansion for Medicaid. We've left $22 billion on the table that could go to help our Tennesseans.
And I assume this would be the prime population who would be added in the expanded folks, because it's people who are probably working, but so they make too much. And they may be single people. They don't have a family that would maybe help them qualify for Medicaid. Dr. Josh, what have you seen?
Every dollar that you put into harm reduction treatment saves $7 in future costs to society and healthcare. Every dollar you put into substance use prevention saves $40 to $50 in future costs.
Yeah, but I imagine it's still a tough sell. Am I wrong?
Yeah, because they say, well, I still have to spend a dollar, right? Yeah, and they'll look at that dollar and they'll say, but I can't spend that dollar, can I?
Yeah. Let's take one more call from Cookeville. Kay, you're on This Is Nashville.
Hello.
Hello. What do you have to share with us?
Okay. I have a son and a grandson in jail. My son in 2011 was in a car wreck, and he, of course, was put on all kinds of medicines, trauma unit for 22 days. And then when he got out, he started going to the little clinics that were set up all over the state.
Pain clinics?
Yes.
Yeah.
Yes, sir. But and which I am totally against. He asked his probation officer for help, and she just turned him into the police, and so he never did get rehab anywhere.
Are you saying that he essentially was needing more pain medication than he could keep getting? No one else would give it to him. I'm assuming he found another way to get it. He talks to his parole officer and ends up getting in trouble, correct?
Right.
Okay.
So I think, and then also my I think it's not helpful if the people that are hired are not looking out for the better interests of the patients, or you might say the addicted person.
Yeah.
You know, also my grandson, he was accepted into a rehab program. His probation, I mean, not his probation, but his public defender got him accepted, and the judge said, no, I'm not going to let him go. I'm not going to send him. And so I'm just having a problem with this, with, I guess, the system that's not really, I don't think, my personal opinion is that they're putting a lot of effort out there to help people because they just have so many people, you know, and they just really feel like the best thing is just jail, prison, whatever. And,
Kay, let us pick that up from there. And so grateful for your call from Cookeville. And if you'd like to join us on the air, the number is 615-760-2000. You're listening to This is Nashville. We've been talking about harm reduction and addiction all week long. You can also leave comments at youtube.com/@WPLN. But the phone number is 615-760-2000. Dr. Josh, what do you have to say to Kay?
I think Kay's getting to the heart of the problem in society is that we still view substance use disorder as a moral failing and not recognizing it as this complex phenomenon that's an interplay of genetics and environment and huge social determinants of health in Maslow's hierarchy of needs. That's the root of what she's recognizing.
Yeah.
Yeah, and Kay, first of all, I just want to say I'm so sorry for this journey that you're on and that you're not seeing, and your son and your grandson are not seeing the kind of support that they need, because this is treatable. I mean, I think at the end of the day, if we all got our arms around the idea that this is a disease and it's treatable, we would have so much better outcomes. And the fact that a judge denied your child access, your grandson access to life-saving treatment, I can't imagine how frustrated you must be. And I'm so sorry.
If you'd like to join us on air, the phone number is 615-760-2000. And again, very easy to drop a comment on the live stream on YouTube. It's youtube.com/@WPLN. I want to get to a couple of things here that, are more newsy, frankly. Dr. Josh, for more than 2 decades, we saw a pretty steady rise in overdose deaths, but now we're starting to see some consistent declines, at least nationwide, and here in Davidson County. But how much do you think can be attributed to the tactics that are being used, like the harm reduction we've been talking about all week?
I mean, a huge part of it is from harm reduction, just having access to treatment, having more providers trained. Big picture, when I was in medical school, which wasn't that long ago, I got a single hour of lecture on substance use disorder. And now that's standardized in every medical school across the country. Narcan training is now in medical school. So all the science and the education is catching up. That's a huge part. Access to treatment is proving. Now, insurance companies are actually paying for treatment. They're providing things like transportation. They're paying for peer recovery services and paying for therapy. So we're seeing things like TennCare. TennCare is actually a huge supporter of substance use disorder treatment in Tennessee. 10 years ago, not a chance. But that's a huge shift that we've seen in the past several years.
Well, and I think we've seen the opportunity that, Dr. Josh talked about earlier, where if you save someone, you give them the opportunity to continue on their journey for recovery. And we have seen the decrease in overdose deaths. And I attribute that absolutely to lots of harm reduction, not the least of which is the Narcan and access to Narcan. In Davidson County, there are now vending machines that are stocked by our health department where you can actually go and get Narcan for free. I carry Narcan with me all the time. And the thing is that is now very different than it was 10 years ago. That would have been seen as something that you couldn't have personally. And now everybody can carry it. And I encourage your listeners to do exactly that.
Yeah, and we even heard people on the air this week talking about, I mean, we had Sergeant Mike Hotz, who's revived multiple people. He was handing out Narcan, naloxone to people who had revived people in their circles. Dr. Josh, your experience?
You want to know a crazy statistic?
Yeah.
There was a study that looked at a huge cohort of patients when you didn't use harm reduction and when you did use harm reduction treatment. On average, if you used harm reduction, you added 12 years of life back to someone.
Because you're saving their life.
They physically lived 12 years longer on average.
Well, and that goes back to if you believe that the value of that person's life is worth saving. And sadly, because we still have so much stigma around the belief that people make these choices, so they've made their choice and, we're done with them. I still want to see that fundamental shift in our belief.
Is it happening?
I think it is because you are seeing a reduction in deaths, and I think you are seeing more access to medically assisted treatment but it's a work in progress.
Yeah. Well, we'll touch on stigma when we get back. We need to take one more break, and we welcome your calls to join us on the air. 615-760-2000 is the number. The lines are open. I'll just let you know the line is not long right now. You can also comment on the video stream, youtube.com/@WPLN. Stay with us as we wrap up our week on addiction and harm reduction in Tennessee. This is Nashville.
Funding for This is Nashville comes from you, our listeners, and Music City Prep Clinic, Nashville-based provider for PrEP and offering comprehensive sexual health services in an environment designed to be safe, professional, and shame-free. Learn more at musiccityprep.org.
I'm Blake Farmer, and this is Nashville. Well, we spent this week talking about harm reduction as a way to get to the other side of the opioid crisis. It's focused more on safety and use of drugs than simply focusing on trying to get people to stop using. And it's your turn to talk. I know that there are thoughts, folks who I'm running into during the day who want to chat about this. It's a complicated topic. There's so much to say, far more than could be said in an hour. But we thank you for sticking with us. Our Roundabout panel in the studio here is Brittany Miller, who's a certified peer recovery specialist, former Nashville Mayor Megan Barry, who has her own story with her losing her son to an overdose, and Dr. Josh Winskowski of Cedar Recovery. I've said all these names now, but we may go straight to the phones. Brad in Memphis, you've been waiting there for a moment. Talk to us about what you've got to say.
Hey, thank you for taking my call. I really enjoyed the series this week. But one thing I haven't heard is with somebody with lived experience, I work for A Better Way. And
a better way is the syringe exchange program.
Harm
Yes.
reduction with syringe service program. I always thought that the opioids, one, they can't distinguish between physical and like trauma or mental pain. And also, like, I only found this in recovery, when I did some reflecting. My sickness, I got COVID in 2020, and I was comparing it to being dope sick. And what I found out was there's a level of anxiety, and I guess, substance use disorder is a spectrum, correct? And from my experience, it was like somebody holding my head underwater and I couldn't get a breath of air. And I think that's what we're not, we could, address all these things. And I think what the doctor was alluding to is, it takes a year or two for that frontal cortex to come back online to give me a stop response instead of just let go. So I kind of have an emotional response.
Yeah.
I mean, it's a lot easier for me to, instead of facing the challenge, especially if you've been homeless for a while, and disconnected from society, and now you go to a 28-day program, you're expected to, live life again. It seems in that perspective, as somebody suffering a substance use disorder, it's easier to just get high than to deal with all these things.
Wow. Brad, let us take that right there. And if you'd like to join us on the phones with Brad, the number is 615-760-2000. But do call soon, because once we get near the end of the hour, hard to take more phone calls. So it's 615-760-2000. Brittany, do people really understand, who haven't been there, what it is like to be dope sick, having withdrawals?
I don't think that a lot of people truly do understand what that is. I think many get the concept that it's purely psychological. There can actually be very physical manifestations of that. People are truly in pain, truly suffering. I don't know how to quite describe it, but it's just one of the worst feelings of ick you've ever had in your entire life. And it's your entire body. And not only does it have physical manifestations, but it clouds you from being able to think clearly and make very wise choices.
And Dr. Josh, at some point, you're just you're chasing to get away from that, correct?
Yeah,
when you're in an active addiction.
You're trying to do things to get rid of the negative feelings and negative thoughts. What can happen, and what Brittany is describing at a physiologic level, there's one of your opioid receptors in your brain called your kappa receptor. And your kappa receptor in active substance use disorder gets upregulated through the roof. And the kappa receptor's job is to try to get rid of bad things. And so as you use more and more, this receptor gets more and more upregulated. And then all of a sudden you stop using, and it says, oh my God, I'm going to die if you don't get this thing that I'm going to do. And it, like the way we studied it too, is so if you add a drug that binds only to that one, it can make somebody acutely psychotic or suicidal just by binding and activating that receptor. And so this receptor in substance use disorder over time gets more and more upregulated. You take away the substance, and all of a sudden it's flaring up and saying, hey, I'm used to having something on me. Please, for the love of God, do something about this. And that's when you see that loss of prefrontal cortex control, which is your insight, your judgment, your emotions. It's who you are as a person. You lose access to that in active use disorder, and we can see that on MRIs.
And Dr. Josh, I'm so glad you said that, because one of the things I was talking to somebody yesterday, and I think the lack of understanding about how much this rewires your brain, and so this idea that there's just just stop. It just, that doesn't exist, because the brain has been so fundamentally rewired.
Well, and I mean, so talk to us maybe for a moment about Max. I mean, what did you see him doing that you're like, this is not even this person?
Sure. I mean, and again, Max's addiction was to Xanax, a highly addictive benzo, and it slowed him down. His thinking wasn't rational, and again, we were lucky he did go to rehab, and that year after rehab, he was in a really good place. But because we didn't actually talk to him about the fact that he was going to have to manage this, like, we really did believe that we just checked a box and that everything was going to be fine and he didn't have to deal with it, because you know why? We did not want the stigma of Max being a drug user to follow him through his life. So, we pretended like it was just, youth, it happens, and now we're done. Not knowing that as he approached that 1 year of sobriety and not taking drugs, that when he did ingest the drugs that killed him on the night that he died, none of them were enough to actually kill him. But because he hadn't actually been using, there were other kids that night that took the same amount and it didn't affect them. But because Max had been, quote, clean, I hate that word, but, he hadn't been using, he didn't have any tolerance. Yeah. And we didn't talk about it. Like, if we'd actually talked about it, and that's why, gosh, thank you again, Blake, for doing this series. I mean, I'm so grateful.
Well, don't thank me. Thank Tasha A.F. Limley, our managing editor, who's been all over it. Brittany.
Just kind of had a thought, as a result of my use and my chronic health condition, I have neuropathy. It's in my feet, it's in my legs.
So numbness in your feet.
Numbness, pain, tingling. It varies in how it affects me, but I have that. And that's a neurological thing. So nobody questions if that pain is real or not.
Even though you could be making that whole thing up.
But doctors understand that it's neurological that causes me to feel those sensations, even though there's no physical cause. Someone experiencing being dope sick, I think, can very much be a very similar when they're having physical reactions to that. Yeah. And that's why it's very important that we have these treatments to be able to stabilize people. When someone is so in the grips of active addiction, it makes me think of something they call the rapture of the deep. And it's like when there's a scuba diver underwater and they've been under so long, they can't distinguish which way is up or down. That's very much what active addiction is like when you're truly in it. So for someone to be able to go in there and point them to which way is up and to get that little bit of hope to see there may be a way out, to me, that's where the change starts to happen. That's where people can actually begin to make decisions about their recovery and about themselves.
I'm going to give out the number one last time, 615-760-2000 if you'd like to join the conversation, but call us soon. Ted, you're on the air with This Is Nashville. Go ahead.
Hey, I'm not sure if you guys discussed it yet, but I wanted to ask about kratom, the sort of South Asian Indo-Pacific plant that now is in most head shops and gas stations everywhere around the country. And I don't think it's been legislated anywhere, but I hear that it can be just as addictive and the withdrawals are just as hardcore as maybe something like heroin. I don't know, but I don't think there's a risk of overdose except for drug complications. But I just wondered if you guys have run into that with your patients or people.
All the time. And I appreciate you bringing this to light, too, because over-the-counter things, alcohol is over-the-counter. Alcohol is the single most dangerous substance that we have. Kratom's the same thing. It's over-the-counter, but I actually treat people and help them get off of kratom because kratom, it binds your opioid receptor. It works just like an opioid. And so I get people on harm reduction, medication-assisted treatment to help them get off of kratom and then address the other parts of life and the chaos that it's created and address the underlying, maybe it's anxiety, maybe it's depression that they started using the kratom for.
You can get, but kratom is also used professionally, correct? At times, or is that unusual?
No, they tried to. It's called metragenine. Metragenine they studied initially, like over in Europe, and they looked at using it for several different things like anesthesia, pain management, and it's not something that's widely adopted or used here in the U.S.
Yeah. Well, we appreciate the call, Ted, asking us about kratom. Not sure we got all the answer that you need, but we're going to go to the phones, try to work in 2 more phone calls before the end of the hour. Laura, you're on This Is Nashville. What do you have to say? Laura, you're on the air if you're there.
Oh, hi. This is Laura. I was just sharing that my husband, who we grew up together, and, when he was 13, he was smoking pot, and then we ended up getting married in 2003, and he came to me 6 months later saying, I have a drug addiction, and I had no idea what was going to happen. And we ended up getting tied into the Cumberland Heights community, and I learned so much about how it impacts your brain function. And the way it was explained to us on the family side is it's like a sleeping tiger. Once they get sober, that sleeping tiger continues to grow and grow and grow and grow. And if they happen to go back out and use again, it's like it wakes up the tiger, and negative impacts of using again, it can be much more detrimental than they ever were from the beginning. And sadly, he ended up dying of an accidental drug overdose. He took something that had fentanyl in it back at the beginning of the pandemic. And so it was just really good for me to learn about addiction and just also learn strategies to take care of myself and do what they call detaching with love. You love the person, but you can't fix them. And that's just been kind of a good life lesson, and the idea of kind of staying in my own hula hoop and not trying to control what other people do, but to take care of myself. So a lot of positive things came out of it, but, sadly, he hit a rough patch and relapsed and ended up dying from it. So,
Laura,
anyway, I just was going to share that.
We're so grateful for you calling and sharing this, and I wonder, Megan Bear, if you have anything to say.
Yeah, Laura, I'm so sorry for your loss, and I think it sounds, and it sounds like you have embraced what this did, and been able to take a step forward in your life, and that is the lesson for all of us who lose someone that we love. We have to keep on living.
Yeah, exactly, and something else that Todd experienced when I asked him when he did come to me and tell me he had an addiction problem. He's like, I'm in NA and I'm good. I've got a sponsor. Well, I called my sister, who was a psychology major at BU in Boston, and who had taken a drug class and was basically like, he's not going to kick this on his own. Like, he's going to have to go to treatment. And thankfully, we got tied into Cumberland Heights. We were very lucky.
Well, Laura, thank you so much for sharing this story. And man, it's been a heavy week talking about this topic, and we leave on a pretty darn heavy note. But Laura, that you put the nail on the head, hit the nail on the head that this is a life and death situation. So thank you for sharing. Thank you to Carol and Nicole, who we didn't get to, who have great stories that needed to be shared, but we didn't quite have enough time today. Thank you to Brittany Miller, to Megan Barry, to Josh Winskowski. This wraps up our week on harm reduction. Thanks for tuning in this hour. This is Nashville's a production of Nashville Public Radio. Today's episode was produced by Mary Mancini. It was directed by Tasha A.F. Lindley, who is the tireless producer behind this entire week of powerful stories and thoughtful guests. Plus, she's making us look good on the video stream, right? Josh Deepin's answering the phones over there. Our board operators, Liv Lombardi. The masterminds behind that theme music are Larange and Namir Blade. You can listen back at thisisnashville.org or wherever you get good podcasts. It's also easy to just ask a smart speaker to play the latest episode of This Is Nashville. The video is archived at youtube.com/@WPLN. The conversation does not have to end. You can find us on the socials. You can also call us and leave us a message, 615-751-2500. This is Nashville. I'm Blake Farmer. Go in peace.